everyone. I'm not sure whether I'm audible, but it seems to me that the IT people told me that I can be starting. Not very sure about the number of participants, but I hope everybody who had joined in is keeping.
Sir, you are audible, and almost 20 people are online, and many more are in the queue, sir. Yeah, I'm going muted.
Yeah, good afternoon to everybody. I hope you people are keeping yourself and your family safe. Webinars are the trend these days, which is keeping ourselves busy in one way. And it is a good opportunity for me to, instead of wasting much time, I also could learn something about a particular topic regarding atrial fibrillation, and I wish I share some of my thoughts about a particular aspect of atrial fibrillation, and that is something to do with the stroke prevention in atrial fibrillation, because we know that atrial fibrillation is one of the important risk factors for embolic stroke. When we talk about the stroke prevention in AF, there is another specific aspect, and that is what is the burden of atrial fibrillation. We will discuss about what we mean by the burden and how that is going to change our decision regarding initiation of stroke preventive measures. And among the stroke preventing measures, I will be specifically focusing on the role of oral anticoagulation with respect to not only the atrial fibrillation part, but the burden of atrial fibrillation. So the topic here is, how do you take into account the burden of atrial fibrillation when you are talking about the prevention of stroke in that population? So in the atrial fibrillation, the stroke prevention strategy so far has been in a binary form. What does that mean? It means we just look at whether the patient has atrial fibrillation or no. And it stops there. We make the decision only on the basis of this, whether AF is present or absent, and this is known as the binary approach of stroke prevention, which in the recent times is considered not really a great concept, because the burden of the AF needs also to be considered. So what does that mean? Why binary kind of an approach is not okay? Because when we say the patient has AF, we do not really know whether that particular patient has had only the first time the atrial fibrillation was documented, or patient has the usual paroxysmal or persistent or long-standing atrial fibrillation. We tend to forget whether that AF was just one episode, and even if it is, when we rule out the reversible cause, and then we consider that first time atrial fibrillation without any reversible cause as a case to be considered for oral anticoagulation. We also do not consider when we label a patient with atrial fibrillation whether that was associated with either an acute ailment or an acute exacerbation of a chronic ailment, for example, ACS or a syndrome of coronary artery disease, which is long-standing, and then there was one episode of atrial fibrillation or multiple. We also do not consider the duration of the atrial fibrillation, whether the patient has got very, very short-lasting atrial fibrillation, or patient gets into atrial fibrillation and remains in atrial fibrillation for several hours or several days. We don't consider that. We also don't consider whether it happens very frequently or only once in a while. We do not really monitor these patients for a long time, so we do not really know what was the percentage of the time during the monitored period the patient was in atrial fibrillation. And we do not also look into how the atrial fibrillation was detected, whether it was just an incidental detection, for example, during a Holter monitoring for some other reason, or maybe the patient has an implantable device in the form of a pacemaker or some other device, and then there was this documentation of atrial fibrillation. So we are now understanding that we should go beyond looking at whether the AF was present or no, but to quantify the atrial fibrillation arrhythmia. And that is what is called looking at the burden of atrial fibrillation. When we look at the atrial fibrillation and stroke prevention, especially with oral anticoagulation, we do not also consider what was the impact if you have prescribed the patient regarding some lifestyle modification regimes, or you have looked at the efficacy of the medications for some of the other risk factors for atrial fibrillation. For example, hypertension, how did you manage? Coronary artery disease, how did you manage? How that is responding to your therapy, and what is its impact on atrial fibrillation? We tend to ignore. We just look at AF, whether it is present or absent, and then we risk stratify them with the Charles-Vaz score or something like that, and then we start anticoagulation. So the binary approach is probably not great. We should be looking at the burden as well as the prescriptions what you have made for his lifestyle modification or the risk factor management. I would focus mainly on the burden of atrial fibrillation and its impact on the so-called possibility of suffering from stroke. So when it comes to oral anticoagulation for stroke prevention in atrial fibrillation, we look at only the binary way of approach, and then we simply figure it out whether the patient has AF, and if the patient did not have any reversible cause for that particular episode, then we straight away start looking at prescribing the oral anticoagulation by taking into account some of the risk factors mentioned in Charles-Vaz score. Those are the CHF, presence or absence of hypertension, age, sex, earlier TIA or stroke, diabetes, etc. And if the score is more than 2 or more than 1 with respect to the gender, we start administering the oral anticoagulation. So we have really made the stroke prevention strategy very simple, but then it probably is not very scientific. Atrial fibrillation burden should also be taken into consideration. Now, when we say atrial fibrillation burden, there is a problem here. There is no uniformity in how do we quantify or how do we define the atrial fibrillation burden. So that has become a major challenge if you consider AF burden to be taken into account in the prevention of a stroke. There are many ways of defining it. For example, one may consider only the number of episodes during a monitored period, and that monitoring method could be many. Every day, counting the pulse or looking at say Holter monitoring, or a patch of event monitoring for a few days or few weeks, or maybe an implantable recorder, etc. So one of the ways of quantifying the AF burden could be simply the number of episodes, but then it has its own limitations. What could be the better definition of the burden is including the total number of episodes plus each episode, how long it lasted. So the total time the patient was in atrial fibrillation should also be taken into consideration. But then it also has a limitation. For example, if a person has repeated episodes of atrial fibrillation, say for example 100 times, when he is monitored, say for example for a month, and if each episode lasted for say only few seconds, its prognosis or the risk for developing stroke may not be as much as a person who had had only 20 episodes during the 100 days of monitoring. And one of the or two of the episodes actually lasted longer. Say, for example, one episode lasted for 1 day, and another episode lasted for 2 days. So this particular patient is at a higher risk than a person who had had more than 100 episodes during a monitored period, but then each episode lasted only for a few seconds. So this also needs to be taken into account. And what is that? The number, the total time, and what were those episodes lasting, say, for example, more than, say, 1 hour or few hours or more than 1 day or 2 days. That needs to be also be taken into account when we describe the AF burden. And then what is also important is how did you monitor the patient for the AF burden? If you simply check the pulse for its irregularity, it may or may not be AF, and then you cannot go on physically checking the pulse all 24 hours. Holter has its limitations, the patches have their limitations, and then you have implantable recorders because of their invasive nature, and maybe because of the cost it can be prohibitive. Now, the concept is good. One should not simply look at the atrial fibrillation issue in the binary form. You should also look at the burden component of atrial fibrillation. It's a noble idea, but the problem here is we are at this stage are unable to define what AF burden is, and we are also unable to accurately measure the AF burden. So these are the limitations of AF burden if you take into account for stroke prevention. And then what is also important is you have a quantified AF burden, all right, but what is the threshold of the burden when you think it should be a risk for the stroke? So that burden threshold also at this point in time is not very clear. Added to this complexity, how do you define the so-called atrial fibrillation when you are monitoring the patient other than the traditional 12-lead ECG? A 12-lead ECG, if you have taken, and that becomes a gold standard. But when you are monitoring the patient, whether he has had an AF or no, you depend on some of the monitoring devices where it may simply say the rhythm is irregular, or it is supraventricular, or it is irregular. It cannot be equated with the so-called gold standard of diagnosing atrial fibrillation, and that is the traditional 12-lead ECG. People have defined atrial fibrillation during the monitored period in many terminologies. For example, AHRE or SAF and SAT, and these terminology further make the things complex. And what is AHRE? It is a atrial high rate episodes. If you are looking at the AF burden, one of the ways of looking at the AF burden is to go through the data that is taken out from an implantable device. For example, a pacemaker. A pacemaker, when there is an atrial lead, is a good device to tell you whether there was a high atrial rate event. And that is known as atrial high rate event, or it's called AHRE in the abbreviated form. But then it has its own issues. After all, the device has its limited intelligence. It might have inappropriately considered a particular event as atrial high rate episodes. Then it would simply increase the AF burden. At the same time, even when there is indeed a high atrial rate episode, the device sensitivity is such that it has failed to detect the electrograms which are arising from the atrium, and then it may ignore, and then it might falsely say the patient did not have a high atrial rate episode. So even though it is a good way, it has its limitations. There's another way of defining the so-called atrial fibrillation episode during the monitoring by a term called SAAF, and that's known as the subclinical atrial fibrillation, which is better than AHRE in the sense whenever you say subclinical atrial fibrillation from the device, you have yourself looked at that event and then you have corroborated that that is an atrial fibrillation. You don't simply take the data from the device and believe it. In SAAF, you have looked at the high atrial rate event and you have confirmed this as atrial fibrillation because of the characteristics of the atrial electrograms recorded in the device. There is another way of monitoring the AF episodes, and one of the terms used is subclinical atrial tachyarrhythmia. Among the three, this is the one which is easier. It would record any kind of an atrial tachyarrhythmia, and it believes that if there is an atrial tachyarrhythmia, it is the precursor of an atrial fibrillation. So we have limitations in detecting the so-called subclinical atrial fibrillation or silent episodes of atrial fibrillation during the monitoring, and hence calculation of the burden becomes difficult. About the tools which we generally use to measure the AF burden, there are many. Well, apart from physically checking the pulse for its irregularity and the rate, one can have some wearable devices, either just a strap or a smartwatch, which could give at the most the rate and the rhythm. But some of the smartwatches can give one lead information in the real time, and it is fairly okay to figure it out whether the patient has an atrial fibrillation or no. And these smartwatches can also give an alert to the wearer, or if that is connected remotely to the clinician, there can be a possibility of getting a 12-lead ECG during that time and to reconfirm. So this probably is very easy to monitor because a person can wear it very conveniently and it can remain with him for a long time. If the smartwatch says an atrial fibrillation episode, or the smartwatch alerts the person that he has got a fast rate and which is irregular, that needs to be, at this point in time, essentially has to be confirmed that that's an atrial fibrillation episode. There are other, if not as convenient as the smartwatches, but there are certain other devices which could also be worn very comfortably. Cosmetically also they are great. It is not really seen and it's convenient. You can take bath. There are certain patches which you can put on the chest, and that would give information about the rhythm, and the electrograms or the ECG traces which are going to be obtained from such patches are of a higher quality than what the smartwatch shows. And these patches can also be remotely monitored. There are better ways of monitoring as compared to the smartwatches and these patches, and it is actually obtaining high quality, almost 12-lead ECGs. But then to wear that on a continuous basis is impractical. Person has to be educated to put these electrodes. There are as many as 6 electrodes, and there is a bulkier device, and then there are some restrictions because the person who is going to use this needs to essentially remove this while taking bath, and maybe he has to remove because it may disturb the sleep during the night time. But the data that is obtained from such kind of a Holter monitors are great, and they are as good as a 12-lead ECG. The best way is to actually have a good quality ECG, and the person doesn't have to bother about it at all. And then those traces or the information of the rhythm could be transmitted remotely to the physician. And that is what is the device labeled as D here. This is known as an implantable loop recorder, which is a small capsule size which could be injected under the skin, and it has a battery which could last for almost 2.5 to 3 years, and it is continuously connected remotely to the physician. But because of its invasive nature and because of its expense, presently this is impractical to recommend this kind of a device only to assess the AF burden. But if that is there, one should, for some other purpose, the use can be made regarding the burden. And those patients who have got already the implantable devices with one atrial lead incorporated, the rhythm monitoring can be great. So you have minimally invasive to almost invasive kind of a devices. They have all got their own advantages and disadvantages, but then they all give to a different extent the information regarding the burden of AF. Now, we have understood a burden is an important component, and then we have understood there are means by which we can look at the AF burden. But when it comes to the clinical management, for example, you have so-called idiopathic ischemic stroke, or specifically if you have investigated and if you have labeled that person who has had an ischemic stroke as to suffer from embolic stroke of unknown source, what is ESS, or it's a cryptogenic stroke. If you have labeled like that, then that there becomes a question mark whether we should give him an anticoagulation. So if that is the question, then we need to be documenting whether there are episodes of atrial fibrillation, and then there's a burden. The smartwatches, the remote smartwatches, the event monitoring patches, or the Holter, consistently they have been shown to be not very useful. What is the Achilles heel in this strategy is that only when you monitor such cryptogenic stroke patients, minimum of 7 days or preferably a month or more, then only there is going to be a yield. So then the question is, should we recommend in such patients an invasive therapy in the form of implantable loop recorder? There is unanimous agreement among the experts that the implantable loop recorders should not be considered at this point in time for looking at the recommendation of oral anticoagulation in the management of further strokes in those patients who suffered so-called idiopathic stroke, because we do not really know what we should do, even if ILR says that there is an AF burden. So at this point in time, the expert recommendation is don't fall for this ILR, because we do not know what do we do. Only when you are into a research project, or for example, in our hospital, we have initiated the observation with ILR. Only when the patients are going to be recruited in kind of a research activity, a person can undergo ILR. But the ILR as an individual case should not be considered for the observation of occurrence of atrial fibrillation. You may prescribe a smartwatch and just to figure it out whether he is having an AF. At the most, you can give him an event patch for a few days or few weeks, or you can also ask him to undergo a Holter monitoring, not necessarily only once, but maybe a few more times. But then implantable loop recorder to assess the AF burden in a person who has had a cryptogenic stroke currently is not recommended unless the person is in a research project. There is, when we talk about the burden, there are ways of looking at it. for example, whether we should really be looking at the burden when we are recommending the oral anticoagulation, or just like the binary approach, patient has AF or no AF, whether that first occurrence of AF, was it really associated with a reversible cause? For example, one episode of an acute fever, or during some procedure, whether there was an isoprenalin, or maybe there was a bradycardia because of certain reversible cause, and that was associated with an atrial fibrillation when there was a recovery. So there are few instances when one-time occurrence of an atrial fibrillation may be confidently considered as a reversible cause, and then that is not taken into account. But otherwise, just a AF episode can be considered as a binary approach, and then whether the patient has AF or no AF, and straight away look at the Charles-Vaz score and start anticoagulation. So there are two approaches. One, think about AF and the burden, or you don't think about the burden and just treat AF. So why there are two schools of thought this way? It is because the authorities who believe, let us not look at the burden at all. Let us consider the AF as just a risk marker for atrial fibrillation, because AF almost always is associated one or the other systemic diseases. For example, dyslipidemia, vascular diseases, some underlying heart disease, obesity, maybe sleep apnea, smoking, hypertension, and diabetes. So the stroke, the feared complication of AF is also exaggerated, or the stroke could also be because of the underlying comorbidities. And like any other comorbidities, AF could also be considered as a comorbidity which pushes the patient to develop the atrial fibrillation. So it just is the risk marker, and not necessarily per se AF is causing atrial fibrillation. So whether the patient has only once or twice or multiple times, whether for a short time or a long time, just do not worry about that burden part. Consider AF as just a risk marker. And so the school of thought does not recommend to look at the burden at all. But most of the people who are involved in the stroke management believe, apart from AF being the risk marker, the AF quantification is also important, because even in the absence of one or more or all of these risk factors, AF by itself may cause formation, may cause the formation of the clot, because AF causes the contractility of the atrium to be lost, and then there is this environment of clot formation, because there is a stasis because of the lack of the contractility. And hence, the people who believe AF per se can also cause thromboembolism leading to stroke, they insist that the burden of the AF should be looked at more seriously, not necessarily AF as the risk marker. But if you are unbiased, both the ways of thinking about AF, either as a risk marker or a per se causing atrial fibrillation, you will have to accept both of these theories. When we agree upon the fact that AF could be only the risk marker, and also that it could also be independently cause independently predisposed for stroke, we should now look at, in case if there is an AF burden, should we now include CHA2DS2-VASc score into the amount of atrial fibrillation or the quantification of the AF burden. More the burden, even if there's a less the CHA2DS2-VASc score, should we consider anticoagulation in a person who has never had a stroke before? That becomes a major question. More the AF burden, even if the CHA2DS2-VASc score is 0, maybe this patient is at risk, because this AF burden that is assessed is not in your clinic, not incidentally during a 12-lead ECG, but this AF burden was assessed because the patient underwent specifically for the monitoring of the rhythm, or this person has had a device implanted, and then you have got this information of the AF burden. And then if you want to do something to do the stroke prevention, whether in this particular patient whose AF burden you have understood, should we now look at that burden from the point of view of the CHA2DS2-VASc score? Could there be a different way of recommendation of anticoagulation in these patients, where now you have gotten an additional information of the AF burden? So that is the present issue where so much of a research is going on. If you know the AF burden, then you can put the patient into 3 zones with respect to the risk of developing thromboembolic stroke. For example, on the left-hand side here is the AF burden. If the AF burden is small, that means the person did not have frequent episodes, the person did not have any long episodes more than, say, for a few minutes, or if the patient has had these kind of silent atrial fibrillation episodes, and then the patient also did not have much of the CHA2DS2-VASc score, say for example 0 to 1, this person now falls into the green zone. You have the record of the atrial fibrillation burden, and you can assess the CHA2DS2-VASc score. If both of them are minimal, then the person falls into this green zone. Another person has had a little more of the AF burden with respect to the frequency, with respect to the duration of the AF, or total time the person was in AF over a period of time. It is little more here, and he also has 1 or 2 or 3 of these CHA2DS2-VASc risk markers. He may fall into the orange zone as compared to this particular quadrant, because he probably has a little more risk for developing the stroke. And you can also see another group here where there is a large AF burden in the form of a longer duration of AF episodes, or longer total time the person was in atrial fibrillation. And if this person also has more than 3, for example, CHA2DS2-VASc risk factors, he falls into this red zone. Well, it's a nice table, all right, but then we really do not know what is this AF burden to be qualified for that person to fall in this quadrant. Whether it is 6 minutes to 5 hours as one particular episode, that should be considered, or it could be even less or more. Similarly, we are not very sure if this is the case, what happens if this patient, say for example, was having a score of 2 or more. We have tentatively put this patient into this zone, which is both green as well as orange. So we are not very sure. Presently, there is no data which tells us how do you put this person into a particular risk category. And presently, there are 2 trials which are going on. nicely designed, but then again, there are certain limitations about these trials. They are respecting the concept that the AF burden needs to be incorporated when you are recommending oral anticoagulation for stroke prevention. And one of the trials is something known as NOAA AF-NET. This is a trial conducted in the cohort of patients who have got implantable devices with essentially an atrial lead as well, to understand the atrial arrhythmia events as stored in those devices, and they are classifying them into whether the person has had high atrial rate episodes. They have empirically considered that as more than 180 beats per minute, and then at least one episode lasting more than 6 minutes. So they have screened. They are screened, and they are continuing to screen patients with implantable devices who have had high atrial rate episodes essentially, and they are also screening those patients with high atrial rate episodes if they are more than 65 years old and at least one or more of a CHAS-VAS score. They are recruiting these patients, and then they are looking at how do they do with respect to the anticoagulation. NOAA AF-NET is looking at the efficacy of edoxaban versus placebo, edoxaban versus aspirin. So the results of this particular trial is going to be available, according to the investigators, by the end of the next year. In addition to this, there is another trial which is almost in the similar fashion. These patients are also with the devices, but here the definition is so-called subclinical atrial fibrillation. When it comes to the atrial high rate episodes, as it was seen in the NOAA trial, here this is a little more stringent. This is subclinical atrial fibrillation. That means the device had told there is a high atrial rate, but the physician also had verified that high atrial rate that in that particular patient was indeed atrial fibrillation. So in addition to having an atrial fibrillation as detected by the device, they are also looking at the age, which is little elderly population, and the patient who have had the previous stroke or some thromboembolic stroke. So there are these two trials now, NOAA and Artesia. This Artesia would help us in treating the patients who have had a cryptogenic stroke or no. And the NOAA is not going to be giving an answer regarding the cryptogenic stroke group of patients. But in general, these two studies will tell us if you have detected the AF burden, how you are going to be managing these patients. These two trials will shed light on the importance of the AF burden. Should we be doing some active intervention in any particular group of these patients with respect to the burden? And we have got two agents here, the edoxaban and apixaban. Presently, we don't have edoxaban in the country. So we might be helped more with the Artesia study in the future, whose results are also going to be available, if not by the next year end, maybe at 1.5 years to 2 years later. So we are at this stage where we have understood more about the atrial fibrillation. We are trying to accept the fact that the binary approach, whether AF is there or no, should not only be the consideration. We should also be looking at the burden of the AF, even though we do not have the clear-cut answer. How do we incorporate the knowledge of atrial fibrillation burden? But then in a particular case, and if your patient for some reason has had information regarding the AF episodes, maybe we could individualize our patient see whether this AF episode is associated with a larger burden. We should also then look at the CHARS-VAS score. If there is a higher CHARS-VAS score, if there's a higher AF burden, after having a word with the patient, with informed consent, discussing clearly about the benefit of the anticoagulation and also the risk of the anticoagulation, for example, the bleeding, we may have to individualize our patients, and then we may recommend anticoagulation or hold back the anticoagulation with this newer knowledge. One should remember whether you are really looking at the AF burden in preventing the stroke in your patient. One thing we should remember that recommending oral anticoagulation may be very easy, but the patient is really at risk of the harm of your prescription, because oral anticoagulation is a double-edged sword. We already know how do we risk stratify the predisposition for bleeding. For example, you can use that Hasbled score, and we also know there's risk estimation with the CHARS-VAS. But if you're also adding the subclinical atrial fibrillation burden or in general AF burden on top of that, and then you are trying to say that this probably is one more indication to start with oral anticoagulation, I request you to be very, very cautious that one should not rush, because AF burden at this point in time is an entity whose value is not very well delineated, or there are no hard recommendations presently to start anticoagulation just because the AF burden was more, or there is no guideline presently to say that your patient has had AF burden which is less. So one should consider that indeed this is an emerging concept, and one day we will have some risk score tables where we can incorporate AF burden, and probably we'll be able to manage our patients better and prevent them from suffering stroke. So with this, I end my topic, and I'm going to be with you people to answer your questions.